everybody. So
Great, we
this
have
is,
recording.
okay, so this is being recorded. Welcome to Redfern Aboriginal Medical Service. Thank you for doing the work that you guys have done under the most, extraordinary circumstances. And this is also a bit of a reminder that we are in the middle of this global outbreak. I know the public have just run a million miles away, but how much of the coronavirus is around? How much does it mean to us? Well, you can multiply by about 3 or 4 the daily cases that are reported. How do I know that? Well, if you have a look at the case positive rate, it's about 15 to 20%. It should be under 5%. So that's the World Health Guideline. So we know we're missing about 60, 3 times as many people as what we're actually seeing. So that says to me, as a microbiologist, lots around, huge amount of community spread. So then we've got, because we're now mixing a lot more, and that's normal, human, we're also seeing a virus, that we haven't seen much of. No surprises there. So these are both RNA viruses, and they've both got capacity, of course, as you know, to change their little bits. For flu, it's neuraminidase, etc., and for corona, it's the spike, the alignment of the proteins, type of proteins on the spike. But really, where we are now, there's been a change. So we accept that both of these viruses are spread via the airborne route. I don't think too many people would go back to the classic transmission of droplet. That's the way we were taught for flu, droplet transmission. Well, move on. So what that means to me is that I've now got to take some or pay some attention to the air in your room. So we know that the thing that works best, of course, is not seeing your patient, but that's a little bit, counterintuitive because we want to see our patients. And so some of you will mix and match to a bit of face-to-face, to a bit of telehealth. What I can tell you is that transmission is really bound up with time, air, and, your P2 mask. So, this is airborne. All I can tell you is when you are in a little stuffy room for hours on end, and you have patients, even with masks, coming in one after the other, you can begin to get a collection of aerosols that simply just remain in that room. And that becomes a heavy enough cloud for you to inhale and pose a risk to you. That's what we seek to avoid. And we seek to avoid it by 3 measures. One is having the patient in for the least amount of time. And if the patient is heavily, symptomatic, see them outside in their car or in a chair or whatever you can do. Some patients are going to be in there and they didn't really know that they were symptomatic or did not disclose. Not having your waiting room there full and with people in there for more than 5 minutes or so. So that's a case of, we call people in when the doctor's nearly ready to see the next patient. That keep risk low. Now, the other thing we've got to do at the same time is look at the number of air changes. And so we seek about, 6 to 8. 6 is not bad, 8's brilliant. Air changes per hour, but how I can kind of put that into a compartment for you, because you really do need to get a technician, an aircon person at your place to actually tell you what you're getting. Because right now, and John has been answering some questions for me, we kind of say, yeah, we've got aircon, heating in the winter, cooling in the summer, but we don't know whether it's fresh or what. But you need about 10 to 15 litres per second per person of fresh incoming air. So, I can communicate with Matthew about that. But what that means is if there's a vent in the one room, in your room, that's bringing in fresh, there'll be a grate that's taking out stale air, or, it's mixing. Your fresh air is mixing. So that's actually a really important engineering control. And when people say to me who don't have anything, no windows, no nothing, oh, can't we just stick an air purifier in the room? I go, well, you've got to have some oxygen, got to have a source of oxygen. But yeah, so you can, with your aircon, you know, your heating aircon, use an air purifier. That will certainly pick up a fair few of the aerosol particles as well. You also want to know, and this is a bit technical, you know, whether I'm getting good fresh air coming in. So it used to be stated 30 to 40% fresh air, but now we're just really looking for some air change. At 10 to 15 litres per second per person is what we're after. So Matthew, there's a bit of homework, and I'm happy to be, you know, texting, emailing with you. So what's the other balance? The other thing is not just air, not just patients, you know, gathering for the least amount of time possible. The third thing is the PPE. So the PPE is actually the least important thing. It's really important, but it's the least effective. So I want to make it really effective, or sorry, if it's the least effective, how can I make it still the least, but better than what I've been doing? And that's about what I wear. So you know that we've more or less discarded gowns unless we're dealing with people coughing and spraying, you know, all over us in a most likely a positive case. So we didn't get good evidence during the flu pandemic of 13 years ago. We didn't get good evidence of transmission back off the gown. So the gowns are basically being dropped, except in hospitals, etc. But what I would expect the clinicians, the nurses, the health workers who are close up to people for any length of time, or even in the same room, especially if I haven't got good air exchange, is it would be all about your face and loads of hand hygiene. You know, gloves are pretty well overworn, and it's really the hand hygiene you do between, you know, before and after contact with your patients. It's the wiping over of the high touch surfaces. It's important. So it's all those three things together. So what I can tell you is, compared to a surgical mask, I'll probably get about a 10, 15% improvement in safety, you know, for myself with using a P2. And, you know, these are 3-layer, these are multi, more than that. Now I've checked with June, and you've got at least 3 different types of P2. So I'm going to show you 2 ways of putting on 2 different P2s. Make sure the P2s, and I do believe yours are all the best ones, make sure they've all got 2 bands that are going to go over my head. You do not want ear loops on a P2, believe you me, rubbish. Let the public wear those. So if I wore an ear looped P2, every time I moved my face talking, I would destroy the seal. So getting that seal on the nose bridge is everything. And doing your fit check. Hopefully you've been off for a fit test, but don't worry if you haven't. But a fit check is what you do every time you put this on. Now, I'm completely overdressed for working in a clinic. So number 1, bare below the elbows as much as you can do. Okay. No jewellery. Your hand hygiene will be compromised with any jewellery. Tear hide, you know, tie hair back, etc. You're stuck with glasses like me, sorry. So first thing, I need this to work. And I want this to not find its way to my throat, even my conjunctiva. Okay? This, the air and how much gathering for how long. This is the way we operate. For the hands, clear, no sores, nails short, no fake nails, no nail polish. John, are you wearing nail polish? Just checking. Always use 2 hands. Don't go like that. You'll never get enough on. It takes 20 wet seconds to destroy, okay, inactivate the spike the ability to get into my throat cells. Okay, it's the spikes are the attachment mechanism. We want to destroy those. So I've got to put enough on. I'm not going to tell you how much, but the technique you use, I usually get my fingernails in there like that. Cover it so it's wet all over. Now rub. And if it's dry by 10 seconds, you've really probably not knocked anything off. So just getting sticky by about 20 seconds will mean that you've had 20 seconds wet contact with that bug. But if people just go like this and a drop, they've not done anything. Hand hygiene is huge, because touching our faces, all that kind of thing. Actually, wearing a mask stops you touching your face. Hands. So to put my mask on, my P2 respirator, I should call it, I'll put on the flat one first so you can see the difference. So with this type, there are two ways of doing it. That's what I should actually show you first. So you can put your mouth in. This is the flatter type. One goes behind the neck and one, as you know, goes on the crown. Okay, no options there. About a third of the way, you can feel the nose bridge, about a third of the way down the nose. Now, don't pinch it and make a V. Won't work. Mould it over your nose. Mould it. Make sure nothing's stuck in, everything's out. Now, to fit check, I want to know if I've got any leaks, whether I have to readjust it. Okay, because all the action is here. So do some heavy breathing, watch it go in and out. I can actually feel a leak under there. So what I'm doing here is I'm looking for any air coming out. Pretty good. Okay, I can't feel easy. That is a fit check. Then I put this on, and you remember to take the seal off. Now, I'm going to mention something a little bit naughty here. I know that this is single use, but if I'm going to go to jail, so be it. But to be able to, I think, extend the life of these, I think we're just going to have to wipe them over each time. So basically, this is what we look like. I'm going to speak about reception in a minute, because really, they should be thinking about maximum protection too. And to take this off, hands, I'll finish with the patient. Back, just touch the back. Then with a wipe, disinfectant detergent wipe. Just get this sorted, sorry about this. It's come out in a double. Wipe the inside first, so it's a detergent disinfectant wipe. Then wipe the front. You really can't wipe foam, you can't disinfect foam. And then hang it. Might as well go fancy. Hang it up. So you're going off for your break. You've worn this for about 3 hours. I just think it's a bit heroic. To ask people to wear this for 4 hours is stupid. You'll become dehydrated. You'll need to go to the loo, all that sort of stuff. You'll need a bit of a mental health break. And to take this off, I've done my hands again. And I'm going to take it like that, without touching it, obviously, at the front and into the waistband. In Victoria at present, I'd be putting masks in clinical waste. They've made a decision about PPE, that if it doesn't get contaminated, it can go into the general waste. I think they've just had so much stuff to put through. That's been the go. I'd be still putting my mask in, definitely. No, but certainly your ear, your eye protection. The face shield will also stop you touching your mask, because every time you touch your mask, you put it in your hands. Well, okay, you have to do that too if you touch the face shield, but I think it's worse if you touch your mask. So masks disposed, then hands, and then I'm ready to go off and take my break. If I've got this sort of a mask, which sticks out, it's going to be a little bit different. So I can put my face in, and I can put one on the crown as before, one around my neck, bring it around here. Obviously you tie your hair back or wear something to cover your head. And again, don't pinch. Mould it over. Make sure there's nothing caught. Do your fit check. See the collapse? Perfect. Great. And I take this one off. If I was to lift that over, I would catch it on here. So what we do for the ones that stick out is we grasp both elastics together away and down and to your hands. So any questions to date? I know what I didn't do. I didn't do a second wipe of the face shield just to, more correctly disinfect it. Before I move on to reception, any questions there about looking after your nose bridge? Anybody got any questions? John, do you want to type anything there? Or ACO? This is what I can tell you. When you go home at the evening, hang on, he's typing something. No questions from him. Before you go to bed at night, get some hand cream, just whatever you've got at home, and go over your nose bridge. Don't do this at work because you'll actually find it hard to form the seal. And then again in the morning when you get up, have your shower, whatever, put some more on, okay? But don't do it at work. That will help the nose bridge. I think you've all seen pictures of what people's faces look like. Going back to what I would suggest is the 3 hours. You will have read people talk about 4 hours. I'm sorry, I just think it's heroic. But, I reckon don't call it a break. I reckon call it a mask change. Because when your mask gets wet, your respirator isn't working. So anybody who says, I think you're taking, you're going through too many masks. I mean, you've got to go through 3 a day. I can't see you can go through any less. So no, when my mask is wet, it's not working. And I need you to have your masks working because I need to make sure all 3 ducts are lined up, that your PPE is working for you, that your air changes are working for you, and that we've got people in front of us for the time they need to be. If we want to have a discussion with somebody, it may be best outside. Outside is fabulous, as you know, or it can be over the phone. But I really like outside. As I said, we can all complain about the weather, but hey, it's 10 degrees here at present, so don't complain to me. Now, any questions at this point? Can anybody come on and talk about that? No. Okay, certainly type them in. The other virus, is it's another RNA virus, influenza. Why are we, and quite frankly, we'll see these 2 viruses coexist quite happily, I think, for the next few months, and possibly with coronavirus might go in. We also know that influenza is not necessarily seasonal. We know that. So the cases we're getting are the ones we predicted. In other words, the vaccine is going to be effective. But for both of these bugs, the vaccine, and I think you know this, is effective at stopping or really having an impact on serious infection. It's not really affecting transmission. And why? Because both of these immunisations are injected. And so that means that the virus will still begin to replicate in my throat before my, humoral and T-cell immune system will, ramp itself up and be able to stop it getting any worse. But that's what's happening for both of these. So while those viruses are replicating in your throat, yep, you'll be infectious to other people. I don't know how well we're going to go with getting a fair bit of the population immunised against flu, but I'm pretty cross about not enough people getting their 3rd shots. You can just see we are not going to get herd immunity with Omicron, with coronavirus. We're just not going to get it. I think we're on about, 50, 55%, and within 12 weeks, because it's a short-term vaccine, and you don't know that till you actually produce it and see what happens. You can't produce a long-term vaccine in advance because you don't know how this thing is going to react. And with the flu, you know that, of course, the way it changes, we end up with often a different one or an extra one the following year. We look to see what the northern winter brings. So short-term immunity for coronavirus, that means we're going to continually have a pool of susceptibles as well as our under 5s. I don't know why we don't have it for the over 6 months, but we don't. I notice a lot more kids being done. Kids are ending up quite sick, as you know, with flu. We then have also our groups who really do need protection. And you're working with a big group in our community with vulnerabilities and comorbidities come off second best with this virus, even if they're immunised. And so obviously, you know, the big call has been to get people with a fourth shot. But it's really the third shot that's really critical for Omicron. And you know that. What's going to happen later on, I don't think it's going to be this year, I was praying it would be, is that there may be an intranasal spray delivery. Now, this would be fantastic for coronavirus because that means I can produce adaptive immunity right where I need it. And that would block onward transmission. Okay, that's the theory. Now, they've tried that in the past with measles. It didn't really work. It was a bit of a tricky thing to do. But that might also help people who are a little bit, I don't like a needle, I don't want to have a needle. So that's in the future. They're also going to tweak the vaccine, as you know, the current one, to Omicron. But really, the third dose is holding a bit. What I find fairly unacceptable at present is 50 deaths a day, Australia-wide, with coronavirus. Of course, my answer, I'm not in charge, would be to keep masks up in public, okay? Indoor public venues, indoor, because most of the spread is happening like that. I know most of the spread is in families. I know that. And even this I know I got from my 2-year-old grandson. But in terms of healthcare workers, a lot of healthcare workers go out of their way currently to maintain their mask wearing when they're at the supermarket. They have family days outside rather than inside. Lots of us have refused birthday parties inside at night time. We prefer lunches because we can go outside. Really hard in a community because, you know, we've been socially, you know, isolated really for a couple of years. But these are the things that I know that healthcare workers are doing. And it's just saying to the public, we're still wearing our masks because, you know, we can't afford to be people down in the clinic. We're doing that. Loads of healthcare workers are wearing masks. I just wish that they'd bring masks in for the public. And I think what's happened is the authorities, the governments, etc., probably when we brought in the mask mandate, it came in as a restriction and it's actually not. It's a precaution. And so unfortunately they were sort of sold together. So your patients are vulnerable, I would really be saying to my patients, I want you, you're a transplant or you're on dialysis or you've got lung issues, I want you to keep wearing your masks. Here's a few masks. I know people are focused on the rapid antigen testing. I'm not sure rapid antigen testing, well, you could argue it's a preventative, but it's a little bit late. We know that these, whilst they'll pick up true positives, they won't pick them up all the time. You'll get a lot of false negatives. We know we've got people at the wrong point in the illness. So now I'm thinking about your staff and what you guys do, and I'm thinking about reception. And what I'm really thinking about here is if I'm at reception, if I'm a staff member, you know, I'm in front of people in that waiting room. What am I wearing? What's the air like? And how long are these people waiting? So I'm trying to reduce their waiting time by just calling them in when the doctor's nearly ready. You know, most of you can work that out. I'm wearing sufficient PPE. If your staff at reception think that this is enough, talk to them about the PPE. It'll give them that 15% extra protection. If your receptionists have got comorbidities, I would absolutely jump into the P2. Talk them back into the face shield. It will give them a little bit more protection around the face. But the air and how long your patients are waiting. Now, you might say, Marg, this is impossible, but that's really what you've done over the last 2 years. And I want to see your clinic open all the time with full staff, okay, as much as possible. With patients, you know, you can call it screening, but, you know, when people are sick, they're not going to be able to answer all the questions properly. But if they wear their mask, you know, under their nose, that's called like not wearing a mask. Are we really going to pick them up on everything? And I wouldn't be hassling people who are unwell. You know, wear your mask properly. If you're wearing a surgical mask, there's no excuse for staff mould it over there. This is the crucial space, flat here, not twisted. Okay, is it being worn properly, or are people doing this? Might as well not have a mask on. Again, remove it and dispose after a couple of hours or so. To remove it, both ear loops away down and into the bin. One more thing for staff, the tea room. And I'm sorry to tell you that I can't make risk vanish just because you're eating and drinking. These are really high risk points. So it's either outside, because we love to be together, for your, if you're going to have a hydration break, toilet break, whatever. Can I be outside more often? Do I want to go to my car and just zone out? Great idea. But I can't make it better for you or less risky if you say, oh, we love our morning tea break for half an hour at 10:30. I don't think you do, but and we all take our masks off because we're eating and drinking and you don't need to wear a mask. High risk. High risk because we're talking, we're shouting, we're laughing. Normal human activities outside. You might say, well, we have a rule of only 2 people and we sit 1.5 metres apart. Well, I've got to tell you, it doesn't count for a lot if your air isn't being exchanged. So you see how these 3 things all work together. Now, that was really all I want to deal with at present, but hopefully I've given you some tips to make life a bit safer. And if you say, we're all going to get it, I don't want you all to get it at the same time. And actually, it's not compulsory to get either infection. I actually think it's worth you not getting the infection. So I was going to finish up there with the 40 minutes and thank you all for coming. But hopefully I've been able to give you some practical tips, but I can't make it all better unless I point out the risks.